Hello and welcome back to another Invst podcast episode. My name is Isaac, and today will be an Invst medical education episode, which will be on diabetes mellitus. So I've taken a bit of a hiatus, and I will explain that hiatus soon in good time. But today, this was a requested episode. I put a poll up on Instagram, and people wanted to hear more about diabetes mellitus. And the reason why I'm using diabetes mellitus or DM over either just calling it diabetes, most people, when they refer to diabetes, they mean this. You have to, of course, realize that there's other types of diabetes. There's diabetes insipidus, there's gestational diabetes, but today I'm focused on diabetes mellitus or mellitus, depending on how you like to pronounce it. So I always try and go through a similar structure, right? So I go with what is it, how does it present, how has this happened, what is happening, and how do we sort of investigate it, and how do we manage it in a broad sense. Now, this is a chronic condition. It's quite a large condition. If we looked at the epidemiology, a lot of people in Australia and perhaps in other places, wherever you're listening to this from, would have it. But before we begin, I always give my disclaimer, my important disclaimer, that this isn't medical advice. I don't know everything. I actually know very little, but I believe this podcast is a way for me to learn, to help go along the learning journey with you. Now, the information that I provided is of October 2023. So medicine continually changes and evolves, and so do the guidelines. So I would always recommend looking at that rather than just using this. But let's get into it. What is diabetes mellitus? So it's a group of metabolic diseases characterized by hyperglycemia, so high blood sugar levels. And there's two primary types. There's type 1 and type 2. And type 1 is more so the result of an autoimmune response that results in a destruction of the pancreatic beta cells. So the pancreatic beta cells are producing something called insulin, right? And this results in an insulin deficiency. And I would recommend going back to your physiology anatomy to looking at that. But broadly, for where most of you guys are at, that's the snapshot. Whereas type 2, which is more common, has a strong genetic component and lifestyle component that it results in more insulin resistance. So the function of insulin, we're thinking that it's going to drive glucose on insulin-independent cells into the cells, right? So we need insulin to remove, glucose from the blood and go into the cells for all the other functions that we know glucose might do. So that's really important. Now, as I said, type 2 is characterized by insulin resistance, but it also can be characterized later on impaired insulin secretion as well. So we could have a relative insulin deficiency as well in type 2. If you think if there's more and more tissue in the body, increasing in body mass, perhaps, then you're going to require more insulin for those tissues. So that's how I kind of think of it basically there. So how does it present? So I'm going to, for the rest of this podcast, I'm going to segment into type 1 versus type 2. So type 1, often the first episode, people can present to an emergency department, which I'm trying to recall, there's probably quite a few conditions like that, but this is something that we're often on the lookout for, and they present in diabetic ketoacidosis. And maybe I can do probably a soon episode on just DKA itself, or diabetic ketoacidosis. But essentially, the key things that you're going to see presenting are the three Ps: polyuria, polydipsia, and polyphagia. So a lot of urine that they're keeping going to the toilet. They'll say, "Oh, I'm going to the toilet so much, I'm drinking so much." The polydipsia and the polyphagia, they're always hungry because they got high blood glucose level, and we can discuss the management of that, or the mechanism of that later. But also, maybe, if we're kind of going a step back, they can have some more non-specific signs like weight loss, blurred vision. They can have changes to, their wound healing, because diabetes can leave you immunocompromised, and then they can be increased susceptibility to infections as well. So someone may not know they have type 1, but they could present with any of those. Now, type 2 is often asymptomatic. Now, in very severe conditions, and usually it affects like an older group, they can have something called a HHS, or hyperglycemic hyperosmolar state, and they could present to the emergency department with that. But that, as I said, more so it's asymptomatic, and you can have the three Ps. Another thing that's important with type 2 is, what I can recall, is skin manifestations. So you can have acanthosis nigricans, which is changing of the skin, darkening of the skin pigment due to hyperglycemia. And so I'd encourage you to look up an image of that to see what it looks like. So we've discussed, how it could present, and we talked about kind of the emergency presentations, but also maybe, less acute presentations. But how has this happened? So type 1, as I said, was an autoimmune condition, and these are associated with human leukocyte antigens, DRA3 and 4. So those with those conditions, whereas type 2 is more your metabolic condition, family history, lifestyle factors that you would delve into in a history. Okay, so what's happening in the body, right? So we know that type 1 is an autoimmune. So what happens is you've got this genetic susceptibility and like this environmental kind of trigger or environmental interplay, right, that results in this autoimmune response and productions of autoantibodies. So auto meaning self and antibodies obviously working against, right? So you can have antibodies against the glutamic acid decarboxylase, which is, or anti-GAD, and different other things within the beta cell, so anti-islet, anti-cytoplasmic antibodies, which cause the destruction of really important factors within the beta cell, within these pancreatic beta cells. This results in the destruction of them. You don't get production of insulin, and if you don't have production of insulin on insulin-dependent tissues, you're not going to be able to take up glucose, and then you have hyperglycemia, so high sugar in the blood. So it's kind of the actual mechanism. Whereas type 2, as I was saying, is more so thinking along the peripheral resistance of insulin. You get genetic factors, you get environmental factors, and you have perhaps obesity being one of the key factors in terms of what can happen there. And what results is that you have increased plasma levels of free fatty acids because of perhaps obesity. You get impaired insulin-dependent glucose uptake into your hepatocytes, your myocytes and adipocytes, and that can influence insulin homeostasis. But also another thing that I was looking at earlier is that you can have a different, I guess, sort of biochemical reaction occurring where more insulin, because repeated amounts of insulin demand, that the tissues become desensitized to insulin. So you get this insulin deficiency. Okay, hopefully those two things make sense. But they are important to acknowledge because I guess some of the complications of diabetes stem from this. So how do we investigate it? So we have a kind of core structure that we use, our bedside, bloods, and special tests. So our bedside, we can do a blood glucose and ketones. So ketones and ketone production, and I talked about diabetic ketoacidosis before, is because if we don't have glucose going in and we don't have glucose utilization, we have to produce energy in another sense for the cells to use, and that is from fatty acid breakdown, essentially, which results in the releasing of ketones, and that makes the blood pH go down and also releases ketones. So that's why the acidosis comes into it. But also you can do a urine analysis and you can have urinary ketones as well, because you just imagine the body trying to get rid of these ketones. In terms of your bloods, you would obviously could do a fasting plasma glucose. You can do an oral glucose tolerance test if you wanted to diagnose diabetes, whether that's in the type 2 setting. A HbA1c is the key one I wanted to talk about, which is conveys the average glucose levels over the cycle, a red blood cell cycle. So the A1C protein is on the red blood cells. Just as a little note here that I fortunate to hear in my placement this week was that in patients with anemia, because they've got deficiency of iron, that can influence the A1C proteins as well. So be aware that checking HbA1c and anemia is something to consider. But going back to this, your A1C is going to give you a more sort of longer term management or longer term picture of what their blood sugars have been like. And in course, in DKA, which is the complication, you'd want to check when you have acidosis, you want an ABG, VBG, electrolytes as well. It's going to be important to check on your bloods. Now, I might have missed a couple other investigations you could broadly do, but those are probably the key blood ones that I guess in that acute phase or in diagnosis that you'd want to do. Now, your special tests, you can do C-peptide. So the C-peptide is cleaved in the production of insulin, and we can tell the difference between endogenous and exogenous insulin by the C-peptide. So if someone's injecting with the insulin, right, that's coming from outside the body, we should be able to differentiate between the insulin that's produced within the body through that. Also, you can do antibodies. I've seen this fortunately again with my placement, the use of antibodies being used, so anti-GAD, anti-ICA antibodies, which again, GAD was that glutamic acid decarboxylase, and ICA was the islet cell antibodies. So I have seen them ordered. So they're the key sort of special investigations, right? But often with the investigation, you're trying to put it in context of the clinical picture, right? With diabetes, that's really important. All right. So we've kind of gone through this initial preamble of what is it and how does it present and how to investigate it. So now let's talk about management. Now, type 1 diabetes is a challenging condition that it's a chronic health condition that people have to go on, regimens of insulin that's lifelong. So there's no cure or reversal or anything like that. It requires, management. And what do I mean by that? Well, you need to engage a multidisciplinary team. So you need diabetes educators, you need endocrinologists, you need nursing staff, you need dietitians. You also need optometrists to look at their eyes because they can get complications, podiatrists for the feet. Even your teeth, you need a dentist to help with some of the inflammatory processes that can go in your mouth. So it's a multidisciplinary care which requires regular glycemic monitoring. So you need to know your blood sugars, and there's a lot of technology out there helping with that, but also anti-hyperglycemic treatment, which is insulin. So I just want to talk briefly on the types of insulin because I think they get thrown out a lot, especially on different wards and emergency departments. So you can have rapid-acting insulins, which in the name, it's going to sort of work really quickly, usually 15 minutes after injection, and it sort of peaks between about the 1 hour mark and can work from 2 to 4 hours, like depends where you read. And you have Nova Rapid or insulin aspart, and insulin glucosamine or Adipra, different plays, or insulin Lispro or Humalog, but I often see Nova Rapid used. So those are the rapid acting, and then you've got short acting. So these work about 30 minutes after injection and peak between 2 and 3 hours, and continue to be effective from 6 to 8 hours. So you can see a bit longer. So you can have Novolin there. So that's the insulin that I've heard of that's used. And you can also have other types of shorter acting ones as well that can work when you're using, well, I guess when it's indicated to use. So when looking at a kind of intermediate insulins acting, right? Because you obviously need to know when they're having meals and when you want to use insulin throughout the day. You can have intermediate acting ones as well. So the common one I've heard of is Protophane. Protophane is used as sort of that intermediate acting, and they often work approximately 1 to 2 hours after injection, peaking in that 4 to 12 hour mark, and remain active for 16 to 24 hours. So you can see that that's obviously quite a longer timeline. And then you've got your long-acting insulins, which people will give and kind of be working in the background when they're having meals, when they're having carbohydrates or sugars there. And the one there that I've heard used a lot is insulin glarginine, which is Opticillin, Lantus, depending where you are, insulin detamir or levemir that you might have heard as well, the ones I've heard. So these usually have a steady insulin, that sort of base insulin, over 20 to 24 hours. Other things that you might hear as well, I might as well mention it because I've heard it quite a lot, is the premixed insulin. So you can have a mix of rapid acting and intermediate acting. So Novamix, Humalog mix, you can have them as well. So you can have mixed formulations, obviously dependent on what the guidance is there. So yeah, hopefully if you were confused about hearing terms of insulin, perhaps on your rotations or ever, wherever you've been in the hospital, hopefully that gave a little bit of insight of timelines and why you could think of the advantages versus disadvantages of those. All right, now on to management of type 2. So type 2, we also talked about chronic health condition, but has that lifestyle factors, and that's the start, right? You want to try and manage those lifestyle factors, whether that's diet, physical activity, smoking, sedentary lifestyle as well. Obviously, physical activity, sedentary lifestyle overlap there. But you still want to have regular glucose monitoring. So we want to know the effectiveness of the treatments and make adjustments, because there are a lot of improvements that can be made from diet, exercise, stopping smoking, improving those factors. However, we still need to monitor those. There's also oral medications that can be taken. Metformin is a large one that's often used. Sulfonylureas, SGLT2s, and DPP4 inhibitors. They're all different ones that I encourage you to go and have a look at. But I'll probably need a whole podcast just to talk about each of those and their mechanisms and side effects. But also we're thinking with type 2, there's other risk factors. So we always think of the macrovascular, so large things versus the microvascular complications and the involvement there. So, blood pressure and cholesterol is going to be really important. Routine screening of the eyes, the kidneys, the foot, and heart is going to be really important. I talked about the dentist as well, and gum health, and engaging with that multidisciplinary team. That's still going to be important for type 2. So considering that as well, and then education as well. So yeah. Let me think if I forgot anything. Oh, of course, alcohol as well. Limiting of alcohol is going to be important. Drinking in moderation and following the guidelines wherever you may be on how to reduce alcohol intake as well can help with diabetes-related complications. And of course, regular follow-up, making sure they have follow-up to manage all those things, because there's quite a lot there. So thank you for joining me for another episode. I hope that was useful. This is a big topic. I went through it probably pretty quickly. But I just wanted to give different snapshots of conditions for you guys out there. Have a listen. Try if you picked up one or two things, then my job is well done. But I'm still learning, still building. So hopefully in the next episode, whatever that may be, I'll expand. But I'd love to do an episode probably on DKA and the complications of diabetes. I think that needs its own episode, probably because there's a lot in there, and you can't kind of just give an overview and snapshot, perhaps. But yep, thank you for listening. I hope that was useful. Looking forward to the next episode. So please, if there's anything that you disagreed with or found you didn't understand, please get in contact with me. You can just message the Invst Podcast Instagram. You can, reply to any of my posts or anything there, or message directly. That'll be great. Or if you know me, you can just contact me normally. And yeah, looking forward to the next episode. On YouTube and Spotify, wherever I can post it, I will. So hopefully that was valuable. Looking forward to the next one. Thank you.